Good afternoon. I'm Janet Shikles, and I'm one of the co-chairs of this conference. And as you heard from Larry this morning, we're doing something a little different this year with our conference. We've organized 2 tracks, one on Social Security and one on Medicare. And I'm really excited about the Medicare sessions, which I've worked hard on with my co-chairs. And I think you're going to find them terrific. So the first one, which is now, is a Reform Medicare Basic Principles. And then later this afternoon, we're having one on competing reform proposals for Medicare. Are they really that different? And then tomorrow morning, a panel on finding consensus on Medicare reform, where we're going to come together with all the answers, right? We hope. Okay, now I'd like to very briefly introduce this really terrific panel that we have. So Bob Reischauer will be the moderator. He's an economist and one of 2 public trustees of Social Security and Medicare. And he's a former president of the Urban Institute and a former director of the Congressional Budget Office. Marilyn Moon is a senior vice president and director of the health program at the American Institute for Research. She's also an economist and formerly a senior fellow at the Urban Institute and also formerly a public trustee for Social Security and Medicare. Dan Durham is the executive vice president for policy and regulatory affairs at America's Health Insurance Plans. Previously, he was the vice president for policy at the Pharmaceutical Research and Manufacturers Association of America. And Gail Wilensky, who very kindly really did come back from the end of the earth, Antarctica, to be with us today. So she gets extra points. She's a senior fellow at Project Hope and was the administrator of the Healthcare Financing Administration, now CMS, and the chair of MedPAC, and previously the Physician Payment Review Commission. And I haven't done any of these individuals justice. The full bios are in your packet. And now I'm going to turn the session over to Bob.
Okay, welcome everybody. This session will focus on Medicare reform from the 30,000-foot level, the basic principles that underlie the program and that shape our discussion about future reform. One of the 2 sessions that's going to follow this one will get down to ground level and discuss the specifics and the strengths and weaknesses of competing proposals. To frame this session, I have a couple of slides, the first of which just lists some general principles that have defined the program since its inception in 1965. To be sure, the meaning of several of these has evolved over the last 48 years, but just let me tick them off. First is that everyone who's 65 and older and is eligible through their work history or that of a current or a former spouse for Social Security should be covered by Part A and eligible for voluntary participation in Parts B and D. This has been expanded over the last half century to include those receiving disability benefits for at least 2 years, and those who have kidney failure, and those who otherwise are ineligible but are willing to pay 100% of the premium for Part A. A second principle is that everyone should get the same minimum set of benefits and pay the same premiums, and that those premiums should be community rated with the community being defined as the nation as a whole. Of course, this implicitly creates huge redistribution because the pay is the same everywhere, but the expenditures are not the same everywhere, as you know. It's also been changed a little bit over the last decade or so to accommodate income-related premiums that affect really only the top 5% of beneficiaries in terms of their earnings. Third, the insurance is guaranteed renewable. You can't be dropped because you're too sick or because you don't pay your cost sharing or because you move to some strange location. As long as the services are delivered within the United States, you can live anywhere in the world. Fourth, benefits are supposed to be similar to those received by the sort of normal employer-sponsored insurance plan. Over time, of course, we've strayed away from this. For a long time, there was a growth of prescription drug benefits in the employer-sponsored world that wasn't matched by Medicare until just in the last few years. And still, there's one glaring place where this principle doesn't hold, and that's with respect to catastrophic coverage, where after 2014 and the beginning of the Affordable Care Act, Medicare will be the only insurance policy available in America that doesn't have a catastrophic cap. Fifth, there's the notion that Medicare beneficiaries should have access to the same providers that the non-elderly use. Sixth, that the beneficiaries should have a wide choice of providers, and more recently that's been redefined to include a wide choice of delivery types, various kinds of Medicare Advantage plans. Seventh, that the insurance should be high quality, by which we really mean it should be the same that everybody else is getting, which is often quite mediocre quality. And finally, that the insurance should be affordable. The definition of affordability, of course, has expanded over the years. We started with Part B premiums amounting to 50% of the cost of Part B, and now it's down to 25%, and costs, affordability has been affected by the duals, by QIMBYs, by SLIMBYs, and QI assistance. The questions, I think, that is before us as we contemplate reform is, must we make trade-offs between these broad principles as we strive to achieve sustainability? And, are any of these principles outdated, ones that we maybe don't have to put as much emphasis on as the original framers of this great program did? Before turning to the three panelists for their remarks, I'll just flash a few slides to set the context on why we're engaged in this exercise. The first being the obvious fact that under current projections, the HI Trust Fund will be exhausted by 2024 and able to pay only about 85% of the anticipated expenditures in HI. Secondly, under CBO's alternative projections, which some people think are more realistic, the growth of Medicare expenditures over the next 25 years is largely responsible for the problems that we have with our budget. Third, for the next 3 decades at least, the growth of Medicare enrollment will be very rapid, more rapid than it's been since the inception of the program, and at the same time, per beneficiary expenditures will grow slower than that they have at any time. Just to end on a positive note, I will flash before you the fiscal year 2012 results from Medicare, which shows that per beneficiary spending rose only 0.4 of a percentage point. It's easy to get excited about that, but we have to remember that there were 2 back-to-back years in the late 80s when per beneficiary spending in Medicare actually declined. So with that, let me turn it over to Marilyn. No, I'm the moderator,
Thank you, Bob. It's nice to be here, and I'm glad he laid out the basic principles, some of them about Medicare. I'm going to talk about some principles to keep in mind for Medicare reform. And one of the, as a preamble to this, one thing I will say is a little kvetch about having Social Security and Medicare split up and in 2 different rooms. Because one of the really important things that we need to do, and this organization is probably in a better position than almost any other to do, is to keep reminding people when they talk about Social Security reform, think about what it means for Medicare and vice versa. Because if you make substantial changes in Medicare on the assumption that people are better off, and then you do substantial cuts in Social Security, you've gotten yourself into quite a conundrum. Moreover, the impact on different groups within the population matters as well, and one should look at the combined effects that way. So that's kind of, that wasn't on my original principles, but it's kind of a caveat here. So I have 6 principles, I think, if I can read my little typing here today. I actually did this a while ago because I was so inspired one Sunday morning, and I thought, okay, I'll just write them all down. The first one, I think, as a principle ought to be, don't blame beneficiaries for high medical costs. We all share that responsibility. Every single one of us, we're all consumers, we all like health care, we use it a lot, and our providers convince us to use it, et cetera. There's a conspiracy of everybody to see the increase in medical costs for the most part, with only a few naysayers out there who often get shouted down as death panel advocates or whatever the role may be. But it is important to recognize that healthcare costs are growing, and that's a problem. But I think that sometimes we talk about blaming the beneficiaries. And my latest pet peeve about that is people who talk about this in terms of lifetime contributions. So what? When I was 35, I was supposed to say, hang on, I'm not paying enough. I'm sure there's going to be healthcare inflation. Let me pay a little bit higher taxes above and beyond what's required. I don't think so. I think that, in fact, that kind of helps illustrate, if you do it right, some of the issues that come up when you have very high rates of inflation, and people who feel that appropriately that they contributed on a certain basis and they didn't either make the inflation be what it is, or they're certainly not solely responsible for it. Principle number 2, be realistic about where competition will work. There are ways in which, as a well-trained economist, I believe that competition is important, that incentives are important, but there are also ways in which aligning incentives does not always mean using the market. We might not always like how the market works, or if we do want to use the market, we're going to have to regulate it very carefully. Because the market working can sometimes mean people get together and lower the prices as they're competing for each other. It can also mean that, that a large firm decides not to let anybody know that there are major problems with the hip replacement tool that they're selling and just keep that quiet so their profits stay high. It can also mean that they compete on things that you don't want them to compete on. And as a consequence, we just need to be very careful and understanding about where competition works. I believe in competition. I just believe it can be bad competition as well as good competition. Number 3, I think that it's important to give changes that we do time to work. We expect miracles. It is not uncommon for legislation for CMS and others to say, let's have a demonstration and see if it works, but you have to have savings in year 1. Well, that's really silly. And we've gotten away from that a little bit with the Innovation Center, but we're still pretty impatient. We want to see those changes really quickly. We want to see them working. We're talking about making changes that are going to change the way the healthcare system deals with people and the way that providers interact with the system, and their entire livelihoods in their minds are at stake. Don't expect them to suddenly say tomorrow, yes, let's change everything. Have all the rules of the game change. Have me held accountable in totally different ways than ever before, and I will happily go along. Most of us are creatures of habit, and we aren't too crazy about that change. So we need to really talk about being patient and recognizing we're going to need some time for these things to work. Number 4, I think it is, bring beneficiaries into the equation. And that is that we often talk a good game in the healthcare world about patient-centric things, patient-centered medical homes. I've heard a number of physicians say, gee, I believe in patient-centered medical homes, and I'm perfectly capable of speaking for the consumer because I know what they want. I don't think so. Consumers do know what they want, and they're going to resist strongly coming along with certain changes if they're afraid they're not going to be in their best interest. You need to get them on board, interested, convinced, and part of the whole solution. They can't simply be on the sidelines. That's happening increasingly, But it's still a case that this is a difficult area, and we do not spend the time, dollars, or other kinds of psychic energy that's necessary to begin to get consumers involved in this whole equation. Number 5, recognize that higher taxes or asking beneficiaries to pay more are really exactly the same issue. That is, who will pay? If you ask beneficiaries to pay more in premiums, if you ask beneficiaries, in some cases even in cost sharing, you're not doing so because you think it's going to change the way they interact with the healthcare system. You simply want bigger bucks from them. You want to pay for the system that way. And that's okay, we may decide to do that, but that is, when you say that's the only way we can go, that is essentially saying we cannot ask taxpayers to pay one more thin dime for this program. So I think when we start to talk about asking consumers, asking beneficiaries to pay more, we also ought to be saying, is that fair in terms of how we treat everybody? Should taxpayers pay more as well? I would guess and suggest that a really good reform, one that really is lasting, will have to be painful to both sides, and it cannot be just one side being asked. So whenever I hear people say Medicare is unsustainable as it is, and we have to cut, I think, why aren't they also talking about revenues? And they very seldom do. It needs to be part of the discussion, and at least we need to give people the chance to say, I'd rather have those beneficiaries get a lot less than me pay more as a younger taxpayer. I think that we need to have that discussion, and I don't think it would turn out the way a lot of people are afraid or think it might turn out. And finally, and very importantly, number 6 is recognize that the challenges facing moderate to low-income beneficiaries are very important, and they need to be part of this whole discussion. This is the fact, among other things, that we have kept low-income protections as a percent of poverty, and hence as a percent of people's incomes, pretty much the same for many, many years. That's why at the same time, why we are seeing incomes rise more slowly than healthcare spending, and we're wringing our hands at the federal payment level, we should be wringing our hands at the low income level as well. That protecting someone at 133% of poverty and then not protecting them at 135% of poverty is very different today than it was 20 years ago. It is a lot less generous than it was because the costs of healthcare are so much higher. We need to raise those low-income protections no matter what, I believe, but especially if premiums or cost sharing are changed, because it will make it so much worse. So I would say that if I looked into my crystal ball and said what should happen in the future, I think if we followed those principles, a couple of things would happen. We wouldn't make stupid mistakes and treat Medicare as part of the budget problem. We would treat it as part of the problem of making this program improve over time and meet people's needs better over time. But secondly, we would also not solve the problems tomorrow. All of you younger people in the audience, and I see some out there, have no fear. There will be plenty of things for you to work on and continue to try to fix as the years go forward, because I don't think we can, nor do I think we should, try to solve all the problems today. What will healthcare look like in 10 years from now? I don't think we really have a clue, nor do we have a clue of what the costs, et cetera, will be. So I would say we should be cautious. We should be anxious to make some changes, but we need to recognize that this is an ongoing and long-term process and not part of a quickie government fix. Thank you.
Dan.
Good afternoon, everyone. I'm Dan Durham from AHIP, and it's a pleasure to be here today to provide you with AHIP's perspective on Medicare reform. As Bob mentioned, the Medicare program is at a crossroads, with the Hospital Insurance Trust Fund projected to be exhausted by the year 2024, and the expenditures continuing to grow as the baby boomers increase enrollment. At the same time, we're confronting the challenge of slowing the growth in federal spending. In the near future, policymakers will need to confront these challenges while improving the quality of care and maintaining value. To achieve these multiple objectives, the Medicare program should encourage early intervention and care coordination while ensuring access to safe, effective, and efficient care. Our members are strongly committed to offering high-quality coverage options to meet the needs of Medicare beneficiaries. Currently, more than 13 million beneficiaries, that's 27% of all the enrollees, have chosen to enroll in Medicare Advantage plans because of the value, the quality of care, the additional benefits, and the innovative services that these plans provide. We strongly believe that private plans can play an important role in Medicare reform. New research is demonstrating that MA plans are improving care for beneficiaries by reducing unnecessary hospitalizations and promoting the use of primary care through transforming the care delivery system. As the national conversation on how to sustain Medicare continues, there are 3 areas where we believe there is consensus. Number 1, healthcare costs are rising at unsustainable rates. 2, quality care should be rewarded rather than the volume of services provided. And 3, systematic change is necessary to ensure that patients are receiving the most appropriate care and in the right setting. To AHIP, this means delivery system reform is essential for the sustainability of the Medicare program. This framework should build upon the health plan practices that improve quality for beneficiaries and reduce costs. Delivery system reform is already in action through the tools that health plans are currently implementing with successful outcomes. For example, health plans are coordinating care by helping patients navigate an increasingly complicated healthcare system, working with primary care physicians to expand patient-centered medical homes to promote care coordination and accountability for clinical outcomes, linking payment changes to new benefit designs that provide information on high-performing providers and encourage patients to use them, fostering disease and case management services, and offering clinical decision support tools with the latest science to inform treatment decisions, reducing hospital readmissions by arranging for regular phone calls and in-home visits for patients discharged from the hospital to ensure that they attend their follow-up appointments, take their medications, and receive the needed home care. And also by utilizing the latest technology to identify gaps in care, target at-risk patients for interventions, and give physicians real-time data on how their patients are doing. And that's something that health plans are very good at. We have a lot of data, and working with physicians who don't have that much data to help them is one way that we're really joining with physicians to make this happen in a very effective way. Results of recent peer-reviewed literature validate that health plans are effectively delivering high-quality, cost-effective care. I'll name a few. A recent study by ARC and RTI concluded that MA plans have added value to the quality of primary care for the elderly by reducing preventable hospitalizations. A recent article in Health Affairs found that MA HMO enrollees experience fewer hip replacements, lower readmission rates, and higher use of cardiac care consistent with national guidelines. Also, emergency department visits were about 25 to 35% lower. Studies in the American Journal of Managed Care found that hospital readmission rates to be 13 to 20% lower in MA than in fee-for-service. And MA beneficiaries received the level of care recommended by a doctor with greater frequency than patients in fee-for-service in 9 of the 11 procedures studied. The strategies that health plans are employing to improve our healthcare system are important and they're working. And to be successful, the delivery system reform must maximize these practices to improve efficiency and effectiveness. We think there are 2 areas where policymakers really ought to focus. One is value-based design. Health plans in the public and private markets today are employing value-based benefit design to promote quality care and cost containment. These tools include cost-sharing incentives to encourage the use of clinically appropriate, cost-effective prescription drugs and the use of high-value provider networks. And second, and this is very important, accountability. Health plans support greater accountability among providers and between MA plans and the fee-for-service program. MA plans have been leaders in the use of report cards to allow beneficiaries to evaluate which providers are best for them. In addition, we've supported the development of performance metrics that allow beneficiaries to compare MA and fee-for-service to help inform their decisions. The good news about the continued availability of high-quality, affordable health plan choices in the MA program demonstrates that our members have been successful in delivering value to the beneficiaries they serve through a system of coordinated care and innovative services. Looking forward, however, we are concerned about the impact of the Affordable Care Act's future cuts on Medicare Advantage enrollees. According to the Congressional Budget Office, the ACA reduced MA funding by more than $200 billion over 10 years. It's important to note that these funding cuts are backloaded. Only about 4% of the CBO projected cuts will have gone into effect by the end of this year. In addition, there's a new health insurance fee, or a tax, that will begin in 2014. An actuarial study by Oliver Wyman found that this new tax is likely to increase MA premiums for beneficiaries, or cost sharing, by $220 per beneficiary in 2014, or by $3,600 over a 10-year period. MA plans also face payment reductions from sequestration and the fiscal cliff bill that reduced MA funding by another $5 billion over 10 years. Now, in evaluating the impact of these funding cuts, it's important to recognize the crucial role that Medicare Advantage programs play in healthcare safety net for many low-income beneficiaries and other vulnerable populations. For years, AHIP has been tracking the government data that show how valuable MA plans are for beneficiaries who are not eligible for Medicaid and do not have employer-sponsored retiree coverage. For many of these individuals, Medicare Advantage may be their only option for comprehensive, affordable coverage. In addition, MA plans are important to beneficiaries with high health care needs. For example, in 2012, all Medicare health plans offered an out-of-pocket maximum, and about 78% of MA beneficiaries are in plans that have an annual out-of-pocket maximum of $5,000 or less. That provides important protection against catastrophic health care expenses that's not found in fee-for-service. Recent data clearly demonstrate that Medicare Advantage plans will continue to do their best to mitigate the impact of the future funding cuts. However, history suggests that it is likely that the estimated erosion of this Medicare Advantage funding will eventually lead to increased costs for beneficiaries and reduce access to health plans. These funding cuts are also inconsistent with the concept of delivery system reform. We believe that health plans are uniquely positioned to promote the types of reform that are necessary to improve quality and promote cost effectiveness. The future of the Medicare program depends upon expanding delivery system reforms currently being implemented by MA plans. In conclusion, we believe that significant changes in Medicare are needed to account for the increasing enrollment and the higher costs. Health plans are taking a leadership role in implementing delivery system reform that could be a model for sustainable reform in Medicare. And the tools and programs being used by health plans are driving innovation, improving care, and containing costs. Thank you, and I look forward to our panel discussion.
Now, this is dangerously close to the not being able to see over the podium phenomenon. One of the interesting things about going last is as people are speaking, you change your mind about what you're going to say. And so there are a few comments that I'm going to make in response to what I've heard. But I thought I would start by commenting on the theme of the conference, which was a cute phrase, but I'm not sure I believe it. We can't keep meeting like this, time for action. Actually, one of the problems when it comes to Medicare reform is we don't have to do anything right now, and it worries me, not because we don't need to do something. The sooner we do it, the more time we have to phase into the changes we would like to see. But actually, we don't need to do anything right now, and I think it is therefore, unfortunately, at least as likely as not. Actually, I think it's more likely than that we probably won't do very much other than attempt to maybe find some contributions to deficit reduction that have very little to do with anything that we would like to have reflecting a reformed delivery system in Medicare that makes for a viable program for the future. We're not really financially challenged right now. There's some debate about whether or not the legislated payment reductions that are part of the Affordable Care Act will play out over the rest of this decade as they're now legislated because of concerns that have been raised by the now retired CMS actuary, Rick Foster, that they may result in access challenges for seniors unless there are some changes that occur at the same time with regard to the delivery system. Even if they do play out as they are in legislation, that only takes us to the end of the decade. And basically people on both sides of the political aisle have projected that the challenges, the financial challenges that we have been speaking about for Medicare will be back with us no later than 2020. And then the kinds of projections that we have seen, which are that in 20, 25 years, we will see spending on entitlements at approximately the levels that have historically represented the share of federal spending, the share of GDP that runs through the federal government. That really abstracts from whether or not at the moment we are at the normal amount of federal revenue with regard to spending or not. It's not quite there, but it's about 17% if you go out 25 years, close to what the historical average has been. And it's really within that context that when you take three programs, Medicare, Medicaid, and Social Security, and play them out, that's what you're talking about. And it really begs the issue that Marilyn raised. I want to come back in a minute, which is to say we need to consider the concept of more revenue. I agree that when you double the population on Medicare, which is what we're talking about once all of the baby boomers reach retirement, that we are going to need more revenue in addition to anything else that goes on in the Medicare changes. But you are talking about something entirely different when you can have the entitlement programs themselves accounting for almost all of our historical share of GDP that runs through the federal sector. And as I said, while I actually support the notion of more revenue will be part of the long-term strategy for making Medicare viable for the future, I am finding it astounding that people are having such short-term memory lapses that they forget actually we have taken one step in that direction. Those of you who don't know it and happen to be blessed with high income will notice it this year in 2013 because as part of the Affordable Care Act, there is an increase in the Medicare tax for high-income individuals on earned income. It goes up not quite a full percentage points. At least as importantly, it extends the higher Medicare tax rate to unearned income as well, which is now amounting to a 4% increase on unearned income. And individuals who are high income will also be facing, as a result of the fiscal cliff, first round negotiations, higher income tax rates, higher capital gains tax rates, higher dividend tax rates, and higher estate tax. So occasionally, when people are saying, oh, but we've got to talk about revenue increases, it's like, okay, but let's not have such short-term memory lapses as to forget that actually the only thing we've done to date is spend more money as part of the fiscal cliff negotiations and increase taxes. And it really does beg the question about what do we do to also try to get spending on what will be a long-term sustainable path. Traditionally in Medicare, traditionally that is like starting in 1965 and not changing, we have focused on one side to try to keep spending in check, and that is on the providers and how we pay providers. That has been historically what we have done in Medicare. Typically, when we have wanted to slow spending, we whack the amounts that we reimburse providers, clinicians, institutions, home care, nursing homes. Occasionally, we move to try to have the spending occur in a slightly smarter way. And that was reflected when we moved to a per-discharge payment for hospitals, for an episode payment, for home care, for outpatient in a bundled payment. Unfortunately, we have seemed unable to make that move for the current leaders of the healthcare team, the physicians, still pay them in the most disaggregated way imaginable. And in the Affordable Care Act, while there are little seedlings being planted that provide the hope for something smarter in the future, it's important for people to understand what we have now in law for the rest of the decade is basically the same dysfunctional reimbursement system under Medicare we have had all along, which is you get more income for providing more and more complex services. Little tweaks are starting. Value-based reimbursement for hospitals this year, starting in 2015, a value modifier for physicians, extended to all physicians in 2017. I think they're perfectly fine ideas. They're tweaking the tail of the distribution and ought to be expected to produce about as much change as tweaking the tail of the distribution would, in your imagination, provide. Maybe some of the interesting innovations that are being started will lead somewhere, will lead to a different way of reimbursing for services. Our history is not particularly promising in that area, but we'll see what happens. We need to understand that because while we like to talk about the different world, and it is in the private sector actually beginning to occur more rapidly, not as rapidly as it needs to, but more rapidly because there's no mother may I that's required in terms of how you change reimbursement. In Medicare, we are basically still stuck with the same dysfunctional system that we have had in the past. The other major question we're going to have to ask ourselves is, do we want to try to more actively involve the users of healthcare services, the seniors? Again, historically, the answer has been no. That is certainly financially what we have done, and not that Medicare doesn't cover or omits coverage of a lot of areas that are important, but in the areas that Medicare covers, when considering the supplemental insurance that individuals have, basically not financially involved, and unfortunately for all of our talk about patient-centered care, not usually in the way healthcare services are provided by clinicians either. Some of that may be changing, but very slowly. More fundamentally, we're going to have to ask the question, is there a way to get the users of services involved in a more thoughtful and better way to help them and to help the rest of us in terms of how healthcare is provided? Again, a little more interesting innovation is going on in the under 65 population, not nearly as much as we need to see, but much more than we have ever seen in Medicare, trying to reward, push, pull individuals to engage in more healthy health habits, to try to encourage them through information and financially to go to more efficient value-based providers. So we'll have to see how serious we are. To date, we occasionally talk a good game. We rarely have put actions behind that. We need to. The longer we wait, the shorter the transition. Too bad for all of us. If we wait long enough, we'll do something probably not very sensible in a short way. I hope you're right with the it's time for action. My gut political response to that is it's hard to get members of Congress to do anything they perceive as negative and painful if they really, really, really don't have to. And other than looking for money for deficit reduction, when it comes to Medicare, right at the moment, they don't really, really, really have to. So I hope you're right, but I fear you're wrong. Thank you.
Okay, we now go into period where you can ask questions. There are 2 microphones on either side of the room, and you can line up behind those microphones. Those of you who aren't fully mobile, raise your hand, wave it. There's a roving microphone somewhere around, and it will come to you. Yes.
Hi, my question is for Ms. Moon. I was wondering if you could talk a little bit more about the challenges facing low and moderate income individuals and what you would do to address those challenges.
Well, I think that the biggest challenge is in terms of assuring that there's access to people to care when they need it, and that they're not discouraged from going to get care at various points in time. This is a population that is particularly frail and vulnerable, and as a consequence, they're the last folks you want to be reluctant to see a physician or another provider early on in a course of treatment. So I think that that's particularly important. And the protections that we have now are you either are a dual eligible, you get traditional Medicaid coverage, or you are in a specific category where your income is low enough that you get some special protections. It goes all the way up to 150% if you're for the prescription drugs, but it's only 133% otherwise. And those individuals in that general income range of around $15,000 a year, when you think that the out-of-pocket costs easily can reach for even a fairly moderate user of health care services $4,000 and $5,000, that's a lot of money that they have to put out up front. And many of them, even if they could get some allowance from physicians and so forth, are reluctant to do so unless they feel they can pull their fair share. So I think that's really where we need to focus, making it both more generous in terms of eligibility requirements, but also more generous in terms of encouraging people, eliminating asset tests, for example, for people at that level. Most people with incomes of $12,000 don't have a lot of assets. They're just not rolling in extra dough out there somewhere. So there are a number of things that could be done that way, but partly it's also finding them and encourage them to use these services, because underuse is a substantial problem as well.
Okay, please identify yourself and if you choose the organization with which you are affiliated.
Paul Sturgill from Hurley, Wisconsin. This is a question regarding Medicare Advantage plans and competition. I focus my law practice in elder law throughout far northern Wisconsin and the Upper Peninsula of Michigan. And so I'm constantly dealing with and advising clients on their Medicare supplemental health insurance plans. It seems sometimes that almost half of my clients have Medicare Advantage. And they almost uniformly don't have a clue about why their premiums are so low. All they know is that they can buy these plans that in many cases have a premium of zero. And they don't really have a very good understanding of what the benefits are. And the plans work pretty well until they get sick, particularly if they have a life-threatening illness. And of course, they have so many plans to choose from, and the idea behind this model is that who can best choose your health care plan than you? But I can assure you that most of my clients don't even know the difference between Medicare and Medicaid to begin with. And then what happens is they get sick, and they have a life-threatening illness, and they want to go to the Mayo Clinic. And they find out that their zero Medicare HMO plan that they get from the Marshfield Clinic requires prior authorization to go out of the network. And then they discover that not only when they go out of network and they don't have prior authorization, that not only does the insurance plan not pay, but neither does Medicare. So I think that this is all based on the commoditization or commercialization of medicine. But I don't think that medicine is like buying a car. So that's my comment, and I'll wait for your responses.
I think, Dan, that's for you.
Thank you, appreciate the question. Ed, I agree that we need to do more to inform consumers about their options, and Medicare Advantage plans do a great deal of that, not only through the information they send directly to consumers, but information that's on the website, information that's on the Medicare website as well. We've got counselors out there in the field that help do that education. But it's also important to recognize the reason why these are high-value plans is because they work with providers to set up a network to help manage care and keep care cost-efficient and high value for beneficiaries. So yes, it's important for beneficiaries to know what they're purchasing, but I think if we're going to move forward in terms of providing a system that provides value, we have to learn from what the private sector is doing, and that is building these high-value networks to ensure that beneficiaries have access to care at lower costs that provides the outcomes that they need to improve their health care.
Most people would not regard being a part of the Marshfield Clinic as a real negative.
Yeah, right.
I mean, it happens to be. I understand if you have a life-threatening illness, you might decide you would prefer to go to the Mayo Clinic or to the Cleveland Clinic or to Texas Heart Institute or wherever it is that you choose. Individuals, if they had wanted to take that option, would have found themselves with a substantial supplemental premium cost, or else the deductions that are associated with both Part A, Part B, and the co-insurance. And it is very clear that when you look at the users of Medicare Advantage, they are disproportionately lower income among the seniors and minorities because it tends to provide a lot of coverage without having to buy supplemental insurance, but that is their choice. If they don't understand the implications of what they're buying, that is a problem. It is why many people turn to their adult children, their grandchildren, their churches, their aging societies, and if it's inadequate information, we need to do something. But I will just tell you, you might want to find a different model because actually the Marshfield Clinic is one high-value place and could do a whole lot worse in this country.
In response to your response, I actually had two cases involving the Marshfield Clinic. One was high-income client, the other one was a low-income client. The first case, the patient had received a diagnosis of stage 3 colon cancer, and the family was shocked because he had been getting a colonoscopy every year, which was a bit strange. And when they talked to the doctor about this, the doctor said, well, last year it wasn't a clear or clean sample. And the gentleman's wife, who had been a nurse at Mount Zion Hospital in San Francisco for many years, before moving back to northern Wisconsin, distinctly remembered that the doctor had commended her husband on what a clean sample it was. And then they also had a son who lived near Rochester, so they wanted a second opinion. And I said, what did you do? They said they couldn't get prior authorization, so they paid $2,800 out of their own pocket, and then the regimen was for a series, either radiation or chemo, for 7 months. The first treatment was $10,000, and I said, what did you do? They said they paid it. And then this was towards the end of the year, and they were able to shift into traditional Medicare SUP. They completed the treatments, and it didn't cost them anything. And the second case was...
I think you made the point.
Okay.
I mean,
Well, the second was a low-income case, but I'll hold that thought.
I just want to say that I think one of the things that we really need to do is make sure that the federal government holds plans accountable for a reason to be participating. It shouldn't just be kind of anybody who wants to participate. There really should be very good oversight and so forth. And I know that there are challenges and problems with even good plans, but But I fear that we still have a mix out there of very excellent plans and very marginal plans, and we need to really make sure that we're doing a better job, or the federal government is doing a better job of helping people not get into those plans in the first place.
And to know the same about the physicians and hospitals that are in traditional Medicare, where it has been traditionally harder to find information about, because the plans, since the get-go, have had to provide much more information on health outcomes and mortality rates, but it is extremely difficult to get information on the individual physicians that you might go to in traditional Medicare. So more information is better. I don't question that.
Yeah, I agree with that, and I think it's a much broader problem than simply the Medicare population. I'm going to hand you all a survey of those of you who are in PPOs with the list of 10 hospitals in the Washington metropolitan area and ask you whether they're in network or out network in your plan, and I'll bet you'll all fail, or the vast majority of you fail, because you don't look at these things until you have to. Yep.
I'm Catherine Edwards. I'm a PhD student at the University of Wisconsin-Madison. I know very little about Medicare and Medicaid, so I kind of have a big picture question. Why is Medicaid administered partly by the states and Medicare an entirely federal program, and how does that interact when you have dual eligibility? And I guess in terms of like the very large picture, not to, I don't know, why are you all laughing? Come on. This is a very big, but.
So how much time do you have this afternoon?
Well, I guess in terms, I mean, the way that I would like the answer directed, if it's possible in a short amount of time, is would it make, you know, reform in life easier is if you got medical assistance or insurance assistance from the government, it all came from one program, and that it was, not that I'm a big government liberal, but I like big government and I'm pretty liberal, but I mean, I'm just not, I'm not sure if in terms of big picture roadblocks to reforming the way that we dispense health coverage with government assistance, is that one of them? Do you think it matters, or do you think it's just that we have such complicated problems and such complicated delivery that that's how
There's
it
some
works?
really good classes in health policy that you can take in this area, but basically it's historically how they were passed. You actually didn't quite describe Medicaid correctly. It is a state program with some federal oversight, whereas Medicare is a federal program. It happened because of what it took to get through Congress in the 1960s, and there are many books on history. And people who are, some of whom are even in this audience, that can talk to you about that history. The fact that people who are in the most vulnerable position and the sickest, the dual eligibles, who have historically been on two different programs that have had zero or close to zero integration, has been noted by many people. There is actively an attempt as part of the Affordable Care Act to integrate the dual eligibles. There's some debate already about how that integration is occurring, but it has been well noted that it is a very peculiar way to provide care to the most expensive, highest using individuals in the Medicare population.
Larry Seiden, University of Delaware. I wanted to ask members of the panel if you think we ought to give serious consideration to the other rich countries who are able to keep their medical costs for everybody 12% or lower. Ours is 18%. That gap has been 6%, something like that, for years. They all use more taxes. They all use more government regulation. They all use a greater role of government. But the result is to get 6% lower in medical cost. Now, isn't that something I'd appreciate not an answer of I don't think it's politically feasible. Put that aside. This is the National Academy of Social Insurance, where we ought to be able to look at what would we think is the best system. Why don't we give that more serious consideration?
Some of us think we had that discussion rather extensively, starting in 2008, 2009, and 2010. We'll undoubtedly have it again going forward. It really is a question of what we can get passed in this country to try to respond to various issues. And I think what we're seeing right now is playing out of what has been a long time coming to try to get as close to full insurance as we can, fully covered population, with beginning attempts to take on some of those other issues. But it's not like we've never had this discussion here. So, I mean, that's just, it is a question of, in a country as large and diverse as this one, what can we get through our political system that will get some of the problems challenged?
With all respect, that is a political feasibility judgment. I just want to know your personal view. What would you like to see if you could get it? What do you think would be best for our society?
I think the other thing that we can't underestimate is that the cultural differences in the United States with other countries and the reluctance of people. It's not a political, it's really a deeply ingrained belief, I think, that they don't trust government, that they don't want this kind of a large mechanism. And I think that that's really a barrier. And if you look at all sorts of attitudes of why we're not like Canada, why we're not like France, et cetera, that comes out very clearly, I think. And so whether or not, in many ways, it would probably be more efficient, but I'm just not sure that this is a society that would tolerate that very well.
But you also think about the kind of system that would work for the EU. Because thinking about the kind of system that's appropriate for the EU is a closer approximation to the racial, cultural, geographic diversity. And I don't mean this just in a political, I completely agree with Marilyn's comments about what it is people want in terms of the role of government and how they look at ways of solving real, important, legitimate social problems. And it is much closer to thinking about, if not all, most of the EU, than it is thinking about any one of those countries, and particularly some of the small, very homogeneous countries like Sweden or Denmark or the Netherlands. And again, not to say that we may not have things we can learn from them about technically how they solve certain problems, but understanding that the kind of diversity that we face here is quite different than what most of these countries face. And when they begin to face some of that diversity, they find some of the challenges that we have found, and in the last decade or two, they have been learning that much, sometimes to their surprise.
Well, let me butt in on Larry's side on this. You know, let's take two of the countries that are at 12%, the Netherlands and Switzerland. And in both of those countries, what the citizens have is a choice among a dozen or so. In Switzerland, it's nonprofits. I don't know what it is in the Netherlands. Insurers.
Regulated.
And you take the voucher, if I could use that terrible term, or the ability to buy insurance, and you choose among them, among those insurers, and somehow they end up spending only 12% of GDP. Now, if I went out to the American public and I said, you know, do you want to have the insurer that your employer says you have to have, or would you rather have this choice of 12? I think, you know, most of them would say, give me the choice of 12. So politically, I think there's another answer to this.
But that is, but I mean, listen, I think that would be great. I would love to have a system like that. I will also say that in and of itself is not going to give you the 12%. It's all the other things.
No, that's what I was getting to. What it is that we pay providers a whole lot more than other people. We do not use more stuff. And, you know, if you go and look across the OECD numbers, you know, my favorite one is MRIs in Japan. I mean, the Japanese must spend half their lifetime getting an MRI. You know, I mean, it's just, you know, multiples of the next country per capita MRIs. So, you know, there you can sort of ferret out where it is. And, you know, we have that 18% of GDP represents huge economic interests that, like any other economic interest, don't want to give it up.
But again, thinking Switzerland and thinking
we'll
the Netherlands versus the U.S., I mean, the complexity of the demographics and the sheer numbers in geographic space. You need to find another example. I mean, that one, it is like saying, can we see something really clever in one of our states and let them work out, and then say, well, okay, let's adopt that everywhere.
Well, and Nancy Altman with Social Security works, and if I can also jump into this conversation, pardon the others, I jumped in line a little bit, because Medicare, and I challenge this idea that the American people wouldn't accept it. Medicare was supposed to be a first step. That, we covered the most expensive part of the population. If in 1990s or in the 2008, there had been proposals to lower the Medicare age, to put a universal Medikids program, which was what the debate was back in the 60s. Do you start with children or do you start with seniors? I think that would have been wildly popular. And as we know, the Medicare healthcare administrative costs, even though we're covering the most expensive part of the population, is less than private insurance. So I think we hurt ourselves by trying to predict what the American public will say, rather than thinking about what it is we want and then how do we achieve that.
There was a group of 76 Democrats in the House who actively kept trying to push a proposal similar to that. It's just, again, the American public can have whatever the American public want, but the notion that in 2008 and 2009, when all of these ideas were churning around, that these issues weren't raised, why don't we lower the age of Medicare? Why don't we have Medicare for all? It's like, I don't know, Joe Baker can probably tell us more than other people, how many times Medicare for all as an idea and concept has popped up on the screen. So I'm not making a comment as to whether it's better or worse. I only am distressed at the notion that there's anybody who thinks this hasn't popped up every couple of years in some way, and very actively from 2008 on in the campaign, and then in all of the discussion and thrashing around in Washington in 2009. I mean, all of these ideas were popping up on the table and other people trying to promote them. So, I mean, you can decide we made a terrible conclusion or decision in terms of what we could get through. I'm into you get what you can get when you can get it, and you try to make it better in the next round. And that is a better way for us to go forward, which is how I would classify the Affordable Care Act. But it's not like it's, did anybody ever think of? It's, my God, I mean, yes, they have. They've talked about it. They've tried to push it. They didn't make it.
Ted.
Well, I have two comments, and I'm not going to frame it in the form of a question.
Identify yourself.
Ted Marmore. I'm the person who wrote a book about the politics of Medicare that the graduate student doesn't know about.
You need to go talk to her after.
Understandably. I just want to say two things clearly and bluntly. First, there is no evidence to support the view that the differences between Canada and the United States were fundamentally ones of value. In fact, the value similarities go north and south and not east and west. And the data on that is absolutely clear. The similarities between Manitoba and Minnesota are greater than the similarities between Manitoba and, for example, Alberta. And it's not that that will tell you how to get it through American politics, because institutionally we're different, but I think it's time to stop using value differences. The striking thing about Medicare in the US in 1965-66 and Medicare in Canada in the 1960s is exactly the same arguments were made for both, exactly. And it was opposed by the AMA and the CMA in both societies, and the institutional differences generated more support in Canada, partly because their provinces took the lead in giving the example. So that's just a factual point. We should not, at the American Academy of National Insurance, invoke value differences where the evidence is not so. That's different from talking about Holland or Switzerland or other places. The second point that I would make, and I'm just going to make two more. Second one would be, we have to think, when thinking about foreign experience, you have to decide, are you interested in the question of how your most similar neighbor or most similar system works as possibly borrowing, as distinct from saying, is it true, is anything true across very different systems? If it's true across very different systems, it's likely to be true for you too. And that bears on what Bob was saying earlier, which is that the common element across all of the OECD countries is that they operate within a budget. They decide what is going to be spent. It has constraints and consequences, but it is true for all of them, directly or indirectly. So American exceptionalism needs to be balanced by this recognition. And on the other hand, the Canadian one, what's striking there is, just I'll give you one example. In 1976, Canadian hospitals were evaluated by the American Commission, the Joint Commission. That is, there was such easy movement between the quite similar hospital systems that it could operate. And it leads me to the last point, which is this. Here is a talk about the reform of Medicare. As far as I can understand, Medicare and budget austerity is the problem, and the expected increase in outlays if the rate of inflation is common. The most obvious thing to say across all these regimes is the law that income on the side of physicians' hospitals is equal to expenditures on the part of the nation. That accounting identity means there is no way to have cost control or reductions in costs without a reduction in the incomes of the people in the medical care industry from what it otherwise would have been. And that's why it must be controversial. No system that I know of in the Western industrial world ever dealt with cost control by delivery reform. They dealt with it by countervailing power and saying to, this was so much going to be available. Now, I agree with you very much that the problems lie in our political arrangements, not in our values. But we at least need to ask ourselves, if we're struggling with spending 18% of GNP, we need to understand the necessary conditions for doing anything about it. And that means the exercise of countervailing power against the demands of people who understandably regard cost control as lowering their income. Thank you very much.
I didn't hear a question mark, so we'll go right to the next person over here.
Yeah, Gail Hunt, National Alliance for Caregiving. And this is a question for Dan. When you were talking about, maybe it seems like in the weeds, but it's something that I need to know the answer to. When you were talking about the tax that's going to go into place on healthcare plans, individual plans, and then you said this is going to be passed on to, as part of the premium to the enrollee, and then when you multiply it out, it's as much as $3,600 over 10 years. My understanding is that what you're calling the tax, is $2 a year per enrollee. I don't see how that gets to, any way you want to count it, how that gets to $3,600.
Well, it's based on an actuarial study by Oliver Wyman that was sponsored by AHIP, and so they took a close look at the premium tax or the health insurance fee that was part of the ACA. In the first year, it's $8 billion, and it applies to MA plans as well as plans that are fully insured in the marketplace. And based on data that they culled through from the NAIC, the Supplemental Healthcare Exhibit, they did an estimate and came up with the impact on MA plans. And the estimate I quoted came directly from their report that in 2014, it's about $220 in terms of the impact on MA plans. And CBO and Joint Tax said that this tax is an excise tax. It'll be largely passed through. And so based on that, if it's passed through, that's the impact that this could have on MA beneficiaries. And over a 10-year period, it increases. So it starts at $8 billion in 14, it goes to 14 billion
whatever.
plus. And so again, it's based on an actuarial study.
That didn't answer the question really that I was asking.
Can I ask where your
if it's
$2 came from? Where did the two?
Okay. Oh, it's just
Oh,
that
oh,
part?
oh,
Oh, that's not,
Okay.
yeah, that's not the
Thank you,
major
Jamie.
Okay,
insurance tax.
okay, that's, thank you,
thank you.
because if I hadn't heard that it was just the PCORI tax, that is $2 incidentally, so that wouldn't matter.
And there are more fees on the way too, besides the PCORI and the
Being a part of
premium
the
tax. There's There's
And for
a
being a part of the exchange.
3.5% tax on
Okay,
exchanges, and the list goes on.
All right. Kike Okma, I'm a fairly recent immigrant. I'm teaching this country, but also in Canada and even in Europe. I was very impressed by Dan's long list of all the fantastic things the health plans can do in this country. It reminds me very much of the Commonwealth Fund's report, and every week there's a new ID that's also good. Now, the one thing that makes me slightly suspicious that you can attribute all of that to the presence of a private plan. There's a whole list of very aspirations that are pretty valid and pretty good by themselves, but you can't have it all. You can't have universal access, good information to patients, freedom of choice, and cost control and efficiency. So I think you need to be a little bit more precise in claiming what it is you think private plans can do good, can do better perhaps than public plans, or the things they cannot really do, say overall cost control. And particularly Switzerland and Netherlands would be very acute cases in which they are embraced warmly because people think, particularly in this country, particularly in the Wall Street Journal, that those are examples of consumer-driven healthcare, make everyone happy and healthy and all that. Well, the reality is more complex and more, I just wrote an article in Health Policy this month, but they can't do it all. They lost their capacity of cost control because the idea was they would be given, citizens in Europe, more individual freedom to choose plans. And by choosing plans, they may have lost their capacity to choose providers. So there's in all those notions and all the whole list of things plans aim to do, seek to do, pretend to do, or claim to do, there's a difference there. There is a trade-off, and they can't deliver it all, whether public or private. And I think some private plans can do something better, but for example, administrative costs are usually very much more expensive because there's more fragmentation, because there's more choice and competition. If you have systems like Germany with only about less than 200 sick funds left nowadays, their administration costs are extraordinarily low because it's standardized, even if it's not a single payer. So I wish you were more precise and more honest what it is you think you really can claim as being unique or better in private plans than public plans.
Well, I think it really comes down to incentives. These MA plans are capitated, so they have to live within a budget. A much different incentive than in fee-for-service. In fee-for-service, the incentive is on volume. When you're working under a capitated system, you have to focus on value. How can you bring the best care to beneficiaries at the lowest price and maintain a high degree of volume and quality so that you can compete in the marketplace where other plans are looking to do the same thing. So it really does come down to incentives, and the incentives in the fee-for-service program are something I think we all agree has to change because it's the wrong incentive to pay for these high-priced services without any really budget there to cap that is what's driving the problem in Medicare. And that's why I was trying to say what private plans are doing in terms of their innovative plan designs, their high-value networks that they construct, their episode bundling payment structures, the value that they're delivering are all things that essentially Medicare is trying to replicate in many of the ACA type demonstrations, but they're often replicated on top of a fee-for-service base that, in the long run simply won't work as effective as what you have in the MA program.
Yeah, I think it was not, there's some confusion in the notion that traditional Medicare, it's not a question of private not-for-profit plan, public plan, but in Medicare now as it exists, as Dan was saying, it is not set up in any kind of an integrated way outside of the patient-centered medical homes demonstration. So it's not that it couldn't be different, but right now, Medicare, it is difficult to provide integrated care in the construct of traditional Medicare. There are a variety of ways that could change, but under the traditional way that Medicare has run without budget caps, there are very siloed, fragmented services, and the advantage that a plan has, it doesn't necessarily have to deliver it, but the advantage that it has, well, okay, no, but we're talking now about in the traditional Medicare program, it has been fragmented and siloed care between Part A, Part B, Part D. It has made it more complicated to provide integrated care. Physicians that want to do that have had difficulties. I mean, they're basically battling the systems. One of the reasons you have the accountable care organizations as a legal construct in Medicare is that if those physicians and hospitals had banded together to share savings from treating a complex patient, they would have been guilty of violating anti-kickback rules and the Stark regulations. Now, does it necessarily have to be? No. But institutionally, at this moment in time, that's what it means. And so we are trying to figure out how to move from where we've been into an area that most of us agree the fragmented fee-for-service system that characterizes Medicare is least suited for the elderly population with their chronic diseases. And it is one of the advantages, again, not necessarily fulfilled, but one of the advantages of the plans that are offered is that they allow for more easy integration and coordination. And they come in a variety of flavors across the country in terms of who's sponsoring them and how well they do. But no, it doesn't necessarily have to be like that. It just, right now, the advantage is there.
Bob Rosenblatt, freelance writer. One of the ideas that's circulating a little bit now among health staffers on the Hill is to have a single deductible, combine Part A and Part B in return for a catastrophic ceiling. I'd like to ask each of you how that fits in with your basic principles of Medicare. And A, if that were done, what would it do for beneficiaries? And B, what would it do for total spending?
Well, we have one of the authors of the original proposal here in Maryland. So.
I think that the devil is in the details. Yeah, I could imagine a combination that I think would be a major improvement and would, for example, for many people, allow them to forego Medigap policies and would allow them to then just stick with the Medicare program and not have to have this combination of wraparound and so forth. The challenge here is that a lot of people that put it out as a way of saving money, and that means you have to have a pretty high deductible and a pretty high stop-loss cap. And the high stop-loss cap is problematic for low-income individuals, as is the higher deductible. If it were more towards budget neutral, which I think you can do, and come out with a pretty good insurance plan, I think it would be nice, it would be helpful, it would not help low-income individuals. It would be very good for sort of middle-income, middle-class folks.
It would certainly be more rational.
Dan?
You know, I think another area of caution here is these proposals are often combined with eliminating first dollar coverage, which is what many of the 10 million Medicare beneficiaries that purchase a Medigap plan, or most are in Plan F. I think that's the highest percentage, which does provide for that first dollar coverage. You take that away and utilization decreases. Now, the studies I've seen can't really differentiate between good and bad utilization. So you require beneficiaries to pay more out of pocket. They may not go and get the necessary care that they need just as much as they may not go and overutilize the system. So I think we really have to be careful about how we talk about eliminating that first dollar coverage and the potential it can have on quality care for beneficiaries.
There's also complication in all of this because, of course, Part B and Part D are voluntary, and not all individuals who are in Part A sign up for Part B. So the question is, how do you treat their deductible? And also with the income-related premiums in Part B and Part D, there's an added incentive for employees of sort of high-wage, high-income employers, like law firms, let's say, to set up some kind of way to avoid signing up for Part B. So it's conceivable that the voluntary opt-outs on Part B and D will even grow over time.
Although it's very small for Part B right now, the opt-out, and
Yeah, and it's all former federal workers.
Yes.
Who have,
either
shall
that
we
or-
say, some say?
either
in,
that or else
political
people who
decisions?
have just become Medicare eligible. So if you took out the people that have just been on the program for a couple of months, then it would be very close to 99%. The Part D, though, is, I think, another challenge in terms of how you would deal with that.
Larry Atkins, president of NASI. So I want to pull back to a higher level question and pose this to you. And this comes back to the American obsession with consumer choice. And choice seems to underlie, an awful lot of the political discourse. And, obviously I think with consumer choice, you assume that things where consumer choice really works are places where consumers are particularly well informed. So I think one of the problems we have is that consumers in the healthcare area tend to be very poorly informed, and it's quite difficult to have them informed purchasers. But cost control presupposes a resource constraint. And so, somewhere in the system there needs to be a resource constraint imposed, and I think a lot of people have been talking about in Europe, resource constraints are kind of built into the system. How do we what limit, and a resource constraint is also a limit on consumer choice. So I want you to kind of address this question of, where do we stop with consumer choice? What is critical in consumer choice? Consumer choice of what? But if you have consumer choice, then how do you balance that with the need to control the use of resources? And what do we do, how do we deal with that? Because most of the proposals on the table for systems reform never really address, at the end of the day, the underlying total cap or limit on total resources in a system.
Well, I think a way to go at that, Larry, is the value-based benefit design to provide incentives both for providers to join high-value networks, which means they have to meet specific quality measures and targets and focus on outcomes for patients, and then provide the consumer the incentive to get their care through those high-value networks through allowing for lower cost sharing and the like. And if they choose to go outside, then yes, they have to pay substantially more. I think the incentive there is both on the provider side to change the payment system, the delivery system, but also to incent the consumer to shop and for value. I think that's the way we start to turn things around.
The question about what consumers want to have choice of it's an interesting one, and it actually, and my observation suggests, has very little to do with whether or not they know anything. They still want to have choice as to where they go. We saw that in the 1990s when people started pushing back. First, they didn't choose the changes in the health insurance plans their employers were foisting on them. They were just presented. Never had that pushback, managed care pushback in Washington, dominated by federal workers who have lots of choices of plans they can exercise every November. They want to have a choice of which physician they can go to. It doesn't really matter whether they have a clue about who is a higher quality or anything else about the physician. They want that choice. They want to be able to choose to go to a hospital if they think that's important. Again, whether or not there's actually any quality reason associated with it. And they've been used to being able, particularly in Medicare, to shop around, less so for the lowest income population because mobility and transportation is a challenge, and everything's many things are a challenge. But for middle-class Americans and higher income than that, they have been used to a very open-ended system and everything associated with that. And the problem is going to be attempting to constrain that is not only not going to win you friends among the provider community whose incomes are going to be whacked, but are not going to make a lot of friends on the consuming community who, by and large, particularly in Medicare, have not had to face that, and trying to figure out what is the most acceptable way to begin to introduce some rational kind of constraints is going to be very important and tricky politically, because we haven't had it. And even if you can say lots of other places do it and the world doesn't change, it's like, yeah, but that's not what people here have grown to expect. And I believe it will be very hard. I do think the fact that we didn't see the anti-managed care backlash among the Washington population and the federal workers is at least one clue that you've got to find a way to have people more actively involved in choosing their poison, so to speak, as to which of some not so great alternatives is the one they prefer, and having some consequences associated with that. If it's imposed on them, God help the employer or the politician that tries. I mean, that's the only thing I'm sure of. Whether the other will work, I don't know.
Another part of this solution has to be, I think, focus on quality. One of the reasons why I have always believed that people want the ability to change doctors is because they want to be able to go down the street and go to somebody else if they don't like what the doctor says to them. And in part, that's because we don't have good ways that people have of assessing the quality of the physician that they deal with or other provider. And so once we have better quality measures and people have more confidence in those measures, then I think they would be more willing to be steered than they are now, because that's your kind of opt-out.
Well, from the insurance company's standpoint, offering a lot of choice is a way of ensuring that you're not accountable for mistakes. It's the individual who's making a decision where to go, and they aren't happy, tough. They bought the bad loaf of bread or whatever. So
Well, it depends what you require in order to participate.
yeah, right. Yeah.
You, Dr. Reischauer, you started the panel with your list of 8 principles that were really the grounding for Medicare, and you ended it with the question, are some of these out of date now? And I don't know whether it's possible to bring that slide back up, but I'd be very interested in hearing from the 4 of you, sort of cut to the chase, and point out which ones of those 8, if any, that you regard as now out of date.
Well, I think we've all agreed or allowed to happen income relating of Medicare, which was, as I think Bob mentioned, inconsistent with those principles, and I think likely to be even more a part of our future, particularly if we attempt to go after some of the adequate coverage for the poor, which I believe is a problem. So that would be definitely one that has at least been modified.
That's a good question, and fortunately, we don't have any time. But yeah, I mean, we can fight it out afterwards. Last question.
You may want to hold this for later, but we'll see. Because one thing I haven't heard really discussed, and I'm curious how it fits into the overall cost problem, is we tend to think in terms of doctors and hospitals. I'm old enough to remember when I could go to the school nurse and get an aspirin. And
now you can go to the supermarket.
And yeah, but you know, we are seeing some urgent care clinics, but community clinics, much more use of nurse practitioners, paying more to our GPs, less to our specialists. It seems to me that's another whole area in this that we ought to be tackling up one side and down the other. Comments?
Probably, I mean, it's what we hope is part of the evolving delivery system that will go to more team-based care and will allow for better integration, which is more sensible when you're treating people primarily with chronic diseases with occasional flare-ups. There was a question, maybe it was, I guess, in the lead-in to our session about whether the financing is consistent with the integration of delivery systems. And in Medicare, it certainly has challenged it.
Before thanking the panelists, just one other comment about the previous discussion about choice and how Americans view all this. I could see this changing rather dramatically with the introduction of the exchanges in the Affordable Care Act, in that a big chunk of the population will be faced with choosing among plans at different levels, you know, silver, below silver, platinum, that have different personal risk versus choice versus breadth of network kind of decisions, which the vast majority of us don't have at this point. And we might, in a sense, educate ourselves and change the way we view our interaction with the healthcare system. Anyway, I want to thank the three panelists and all of you for a good set of questions. Thank you.